Well, thanks, Lenny, and thanks for this opportunity. I've actually never given a talk following someone who spoke about GE. And it actually reminded me of a story that I'll have to share with you. And then, so my brother is, some muckety-muck in the corporate world. And he was on a flight cross country, and sitting next to him was a woman who kept looking out the window and looking backwards and becoming increasingly anxious and agitated. So my brother, who thinks of himself as a seasoned traveler, said, well, is everything all right? And so this woman says, well, I'm looking at the engine on the jet, and it's shaking and vibrating, and I'm worried. So my brother does his best to reassure her, saying, these planes are well inspected, this is all normal work, everything is fine. And this goes on for quite a while. And she continually looks. And so he tries to change the subject. And he says, so tell me, what do you do? And she says, oh, well, I work for GE. And he goes, oh, what do you do for GE? She says, I design jet engines. At which point, he has a complete breakdown on the flight. And she has to calm him down, explaining the engineering that went into and that it was a normal vibration and everything was going to be fine. So that's my GE story. I think that the talk is probably going to go downhill from here. So Lenny asked me to come talk a little bit about the strategy that we're taking at the national and in many respects at the international level when it comes to targeted therapy. And for the last few years, we've been discussing how can we best position a large clinical research enterprise both to leverage discoveries and stimulate discoveries. And so we decided to consider the clinical research landscape, and there were really four realms that we're going to intersect that we thought are going to be major factors in our considering what strategy to pursue. The first is the existing national clinical trial infrastructure. And we'll talk about the Children's Oncology Group and its history and why that was such an important factor, but also changes that were taking place that directly impact the AYA population at the national level. The other factor, of course, was the increased pace of scientific discovery. And we knew that whatever we envision today, that pace is simply going to increase. And when you have a large enterprise, how can you make that enterprise more responsive to this pace of scientific discovery? But despite those advances in science, we knew there were large gaps, that for many of our cancers, there were clear gaps in knowledge that really cut across this cancer spectrum. So with all these challenges and opportunities, one of the other underlying realms was decreased funding. So let me talk about these four realms and how it informed us to move forward strategically in a couple of areas. Let's talk about the national clinical trials infrastructure. So the Pediatric Cooperative groups date back now more than 60 years. The reason that's important is that pediatric oncology evolved as a subspecialty alongside clinical research. And as I think any pediatric oncologist in here can attest to, if you want to see a pediatric oncologist panic, you let them know there's a new patient in the clinic and there's not an open study. That's how closely research in clinical care has become ingrained. At the end of the 1990s, there were four primary research groups in the United States. And really under the leadership of Archie Blyer, who I would say was the principal architect of this, these four groups merged in 2000 to become the Children's Oncology Group. The Children's Oncology Group is international, but in the US, there are more than 200 research sites, and 90% of children with cancer are cared for at one of our member sites. Now, not all of them participate in research, many of them do, But with 90% of children being cared for at one of our centers, this, I would say, is unique in medicine today. It is a near population-based research network that can capture virtually all children with cancer. Where do we begin to fall off? Not surprisingly, in the older adolescents. With a 50-plus year track record, one thing that COG and its institutions do well is they accrue to studies. And the only time we don't accrue to studies is when we don't have a study that's open. But if there's a study that's open, we accrue well and we accrue consistently. Well, with this background, the National Cancer Institute undertook a restructuring of its other adult cooperative groups. And this initiative, which was termed Transforming NCI's Clinical Trial System, was driven by a number of factors. So up until 2 years ago, there were a total of 9 NCI-supported cooperative groups. And it was recognized that not only was this introducing inefficiencies at a number of levels, these groups were not well coordinated, and there was a real struggle to complete too high a fraction of the trials that they were performing. And what was proposed was a merger and consolidation and development of a network. And this is a busy slide, but the crux of it is down here in the red box, that there were going to be 4 adult groups and the Children's Oncology group in a network such that any group that opened a clinical study, that study would become immediately available to the entire network. Now, from a COG perspective, having gone through a consolidation 14 years ago and knowing both the pros of that consolidation and some of the challenges, we looked at this with a good deal of trepidation, because we did not want to get caught up in some of the challenges that we knew would emerge. However, the great opportunity here was clearly going to be for adolescents and young adults. Our ability to extend our research into the adolescent and young adult population, as well as research from our colleagues, their ability to extend it down to our older adolescents, is clearly going to be facilitated by this new network. And that really trumped all the various headaches that have emerged in this process. Let's move on to the next realm, and that's the pace of scientific discovery. And you've heard it here today in a number of talks, and I think this slide, which you're familiar with, best exemplifies this, and that's the cost of sequencing a genome. And this was following Moore's Law. So Moore's Law was, I think, predicted in 1965 that the number of transistors on an integrated circuit would double every 2 years. And the corollaries there is any technology-driven field, the cost of that technology would be halved on an every 2-year basis. And certainly for sequencing, that's indeed what was happening up until about 2007. And with what I would say very few people predicted, that changed pretty dramatically in 2007, and Moore's Law was violated by a significant degree, with the cost plummeting. For someone who does not do genomics on a regular basis, if at all, my take from this was that the technology and cost of omic research is no longer the primary limiting factor for discovery. I think that's not where we're going to have our challenge. Molecular stratification, classification has already integrated itself into a number of areas for the Children's Oncology group. It will increase further in the upcoming years, but for children with ALL, AML, neuroblastoma, rhabdomyosarcoma, and now medulloblastoma, it is becoming central to how we assign patients to various strata or to various studies. But not only has molecular stratification impacted therapeutics, we know it has helped accelerate discovery. And Charles spoke about this earlier. The Target project was really a great example of how one could leverage this national enterprise and the Children's Oncology Group to lead to a number of discoveries, most notably the Philadelphia-like ALL. And I would say, and this is work that you saw from Catherine that Charles presented, and he was being too modest, but work by Charles, by Mignon, Steve Hungers, and many others is going to catalyze how we bring precision medicine into childhood cancer care, how we bring precision medicine into ALL in a way that I don't think we could have predicted 5 years ago. Well, the next realm is gaps in knowledge. And among the other first for me is being put into a pathology session, because I'm not a pathologist, but as you've heard earlier, I rely heavily on our colleagues in pathology. But we do know that classifications, and in this case for childhood cancer, the ICCC classification, which has served us well, will have to evolve. So if you go to the SEER or the ICC website, you'll come up with, and please forgive me for the pathologists in the room, at least 140 different subcategories of cancer. And you can drill down even to a more precise level, and that number goes up. And the pie charts we're all used to seeing where we group diseases, we know that is no longer how we're going to be either thinking about diseases or treating diseases. The molecular classification is going to take what are already small populations of patients and divide them into increasingly smaller subpopulations of patients. And that's going to be across the board for childhood cancers. And so finally, the final realm we had to consider was decreased funding. And I think the one thing that we know with certainty is that this problem is not going to get better in the U.S. anytime soon. It will be with us for, I think, a good number of years, and it is the new reality. The NCI budget, the NIH budget is under increasing pressure, and if you can count on Washington to do one thing, that is nothing. And so that is going to impact everything we do. So let's talk about decreased funding. We now have a great deal of experience in yelling, crying, screaming. It has very little impact. And so the other option we looked at in the Children's Oncology group when you're faced with decreased funding is how can we improve efficiency? And when it comes to clinical research as well as discovery research, we saw an opportunity. In the Children's Oncology group, we had a number of protocols that were biology protocols. For many of these protocols, this was a gateway to eligibility for clinical trials. For all the protocols, it was a resource for future research. In essence, the only thing that differed between these protocols was the name of the cancer. And this evolved over many years, has served us very well, but in looking at improving efficiencies, if the only thing that differs amongst protocols is the name of a cancer, there was an opportunity to try to improve efficiency. But perhaps as importantly, we knew we were not going to be able to set up a biology protocol for every childhood cancer that existed. We simply wouldn't have the resources, and too many cancers would be left behind when it came to understanding their biology. So with that background and those four realms, we have developed a strategy that we're now, I would say, early on in implementing that considers those four realms and both will serve us well for clinical research and we believe will also catalyze discovery. And it really rests on what we've been talking about today, and that's the ability to link omic data to clinical data. I do not know what the best omic test will be tomorrow, let alone 5 years from now. But I think we all have a reasonably high degree of confidence that whatever that testing may be, if you don't have well-annotated biospecimens, you're going to be much more limited in your ability to find underlying causes as well as potential new treatments. And it was with this background, with the goal of being able to link biology to outcome, that we've embarked on what we're calling Project EveryChild. And what Project EveryChild will be based on is a single protocol that will be open to every child with cancer throughout the COG. Every child with cancer in the US, Canada, Australia, New Zealand, and select countries in Europe. And the idea is it will serve as a registry for all children with cancer. It will serve as a gateway to our therapeutic studies for eligibility screening, and as importantly, it will capture the biology and outcome of all these children. For children who do participate on a therapeutic study, we obviously have much greater granularity on the outcome, but even for those children who do not participate on a therapeutic study, we plan to capture it, and we plan to capture it for every child and every type of cancer. And how this will work is really going to leverage the great expertise at all of our COG member sites, that every child who is diagnosed with cancer, there will only be one study that will be the gateway, and that's the Project EveryChild study. When they participate, biospecimens will be sent to our biorepository in Columbus, Ohio. Data will come to the data center. For those children where their therapeutic options include clinical trials, the biorepository will send those specimens for various diagnostic tests. For those that there is no clinical trial or that choose not to go on a clinical trial, their outcome will nonetheless be followed. From a discovery standpoint, it's the back end that we think will be a resource for the scientific community, because these biospecimens that are linked with outcome data will be made available to laboratories across the world. And thus, Project EveryChild's first protocol, which is primarily for newly diagnosed patients, will set the stage for the next generation of discoveries. But we also recognize that our knowledge of relapse is exceedingly limited. It is being led by our understanding of ALL and the work, some of the work you've seen Charles and others present today, but it is quite limited. And we were fortunate enough to 3 weeks ago announce that we are going to start Project EveryChild, a pediatric match protocol. And this is leveraging a trial that has been about 3 years in the making in the medical oncology community, the molecular analysis for therapy choice, or NCI match. And at a very high level, what this will do is patients' tumors at time of relapse will be sequenced to identify specific molecular changes. They'll be assigned to a relevant drug or regimen if such a relevant regimen exists. It was recognized that there will be a need to sequence a large number of tumors to have sufficient numbers to interrogate certain targets. And the payoff, of course, was that sequencing and progression to further illuminate resistance mechanisms. And schematically, the plan right now in medical oncology by NCI-CTEP throughout the network is to enroll up to 3,000 patients, see if there are any actionable mutations detected, and then if there are such mutations that include a therapeutic agent, to enroll patients onto that therapeutic phase 2, follow them until progressive disease, and potentially at time of relapse see if there are other actionable mutations. Most importantly, NCI-CTEP has spearheaded collaboration with an increasing number of companies. One needs a significant portfolio of therapeutic new drugs in order to make this work. There are a lot of companies out there doing this type of sequencing and advancing the field. However, linking it to investigational drugs, we think, and I think our adult colleagues agree, will help drive accrual. This is a very complex and arduous undertaking. Part of it, of course, requires that there's a fast turnaround time between receiving a biopsy and determining what assignment would be made. Right now, that turnaround time is estimated to be 10 days. This is where the field stood about 3 months ago. The adult match trial is a bit behind timeline, but I think is slated to open in early 2015. but there was absolutely no activity going on from the NCI when it came to precision medicine at a national level for children with cancer. And that is where an increasingly robust advocacy community came into play. This included not just advocates, but also friends in Congress, where the, I think, last remaining nonpartisan or bipartisan issue may be childhood cancer, and there's a childhood cancer caucus. Although I don't think there would be necessarily a public acknowledgement of that, Dr. Varmus was able to identify funding, and as I said, about 3 weeks ago, announced initial funding to support a pediatric match study, which is really, I think, exemplary of how an advocacy community can impact research. We have an initial $3 million, which is not sufficient, but it's certainly sufficient to get us started, and we have an increasing philanthropic support. This study will do two major things for us. One, it will significantly increase the number of therapeutic options for a subset of patients with cancer. We know it's going to be a relatively small subset where we can find actionable mutations for which there is a therapeutic agent. What that estimate is, I think, is open to debate. It's probably in the 10 to 15% range and will vary with disease. Eligibility right now is for children with relapsed or refractory solid tumors, brain tumors, and lymphomas. Leukemias right now, the early discussions will not be a part of the therapeutic end of this. And in large measure, that has to do with the rapidity of disease progression and the challenges of using single agents in a relapse setting. But being able to capture the biology may be achieved on this protocol, but as you'll probably hear from others, including Steve Hunger, we have other strategies for our patients with ALL at the time of relapse with the more recent protocol that you heard referred to earlier with blinatumomab in late development. This is a complex undertaking, and we've set up a number of working groups to begin this work, and we're hoping, and it's an ambitious timeline, that a year from now we will be ready to move forward. Key to all this is access to the therapeutic and investigational drugs, and without the partnership of the NCI-CTEP, I think we would not be able to do this. But the other approach strategically that we're taking has to do with increased global collaboration. As we look at the molecular classification of diseases, we know that these subpopulations may become exceedingly small. And currently, we do trials where the incidence of cancer is under 100 patients a year in the U.S. and sometimes closer to 50 patients a year in the U.S. That's remarkable in a research, whenever you think about research in rare diseases. But that is likely not going to be sufficient when it comes to trying to do timely research for some of these rare subsets. I mentioned that COG has a number of international partners beyond Canada. Some of our colleagues from Australia and New Zealand are here. We have colleagues in Switzerland as well as Northern Ireland. We have great collaborations with European colleagues, and you're going to hear from Andrea Biondi in a moment. I think he'll touch upon one of the more successful collaborations that came in Philadelphia chromosome-positive ALL. We envision that being a model for greater global collaboration in rare subsets of diseases. We have done studies, biology studies, where the incidence of diseases differ with India and a much higher incidence of retinoblastoma. We have had successful collaborations. We are now moving forward with our first collaboration with the Pediatric Oncology centers throughout Japan. This is going to be in hepatoblastoma, but again, here we envision that we will continue to build on this experience for other diseases. We are in discussions as well with South Korea to pursue some studies. Both of those countries obviously have a great deal of experience in taking care of children with cancer, but international collaboration, I think, has a lot of challenges and issues that we will have to work through as we try to work more closely with our colleagues in Southeast Asia. We have done studies with South America and have helped them establish a consortium. And again, here, for certain diseases, we're going to be looking to collaborate with colleagues there. We believe we're going to be well served from both a clinical trial standpoint as well as laying the foundation for discovery through these two bookends of protocols. For newly diagnosed patients, Project EveryChild's Biology and Outcome Study. For relapsed patients, our MATCH protocol. We believe that this is the way forward where we will bring together, and this won't show up very well, but we will bring together the biology and outcome both at diagnosis as well as at relapse so that we can have great scientists like Charles and others begin to dissect the challenges that remain in childhood cancer. So that is a brief summary of Project EveryChild, and I think we're going to wait on questions till a little bit later. Thank you.